Menegozzo, do you want to introduce Dr.
Yeah.
Menegozzo?
Okay, good morning, everybody. Welcome to Telemedicine Grand Rounds by the Pan-American Trauma Society. We are going to year 13 of this meeting. We are very happy to announce today the presenter, Dr. Carlos Augusto Menegozzo. Dr. Menegozzo is an attending surgeon and director of surgical point of care at the Trauma and General Surgery Department da Faculdade de Medicina da Universidade de São Paulo, University of São Paulo Medical School, São Paulo, Brazil. Dr. Menegozzo is also one of the biggest leaders of trauma in Brazil and the director of ISBAC, the Brazilian Trauma Society. Dr. Menegozzo, thank you very much for presenting this case today. I'm looking forward to hear and to learn a lot with this case today. Thank you. Please go ahead.
Well, thanks a lot. Thank you for the invitation as well. I love to present the case here with you guys in the PTS. So this is a rather straightforward case. I'm not going to put anything like any traps here during the presentation, but I'm really interested in hearing what you guys will tell me about this case, because there are some specific points that are really interesting to discuss. And this is a pediatric trauma case, so it's not every day that we have such cases. So that's why I'm bringing this case for discussion. So as always, I'm going to present the case. We're having some questions and some discussions during the presentation, and on the last 5 or 7 minutes of the presentation, I'll bring you guys some learning points that that were learning points for me as well, and I wanted to share with you to make the discussion more rich. So this is the title: Seatbelt, Friend or Foe. You're going to understand why this is the title of the presentation. So this is a 6-year-old male patient. He weighs 25 kilos. And the mechanism of trauma he was involved is a motor vehicle crash. The patient was actually on the back seat, and the car was going around 75 miles per hour. So it was really, really fast. The vital signs at the scene: the patient was Glasgow 15. His BP was 100/70 and heart rate of 130. And he took almost an hour to get to the hospital. He was transported by helicopter. He was far away from the hospital, and he got ringer lactate on the scene and also intubated to be transported safely. And this is the picture of the first assessment of this patient. He was intubated with the cervical collar. He had a reduced breath sounds on the right base, but his O2 set was 100%. And he had a heart rate of 132 inside the hospital, a systolic blood pressure of 85. His radial pulse was palpable. His skin was okay. He was not pallor. And he had a Glasgow scale of 3T because he was intubated, reactive pupils, and no extremity deformities. And I know that you guys want a lot of information, more information from the first assessment. But before giving you more information, I wanted to invite you to share some insights about some aspects of this case. So the first one that I would open to the panelists for comments is: how would you interpret this mechanism of injury in this pediatric patient, especially considering the differences between the mechanisms of trauma according to adults and also to pediatrics, and the difference between them? And also, how would you interpret the physiologic findings of this patient in this first assessment, this first phase of the assessment? And are there any difference from the adults that we should be aware of while we are treating this pediatric population? So it's open for discussion.
Thank you, Dr. Menegozzo. Dr. Unjak, do you want to go first?
Yes. So about the mechanism of injury, so I assume it was a head-on collision with a stationary object, or actually maybe you could tell stationary or with another car. I assume it's a stationary object, the one being goes 75 miles an hour. And And then I can see from the picture, it looks like the child was in on the passenger side and the rear, looks like a seatbelt mark. And usually in the States, children need to be in special child seats till they're about 6 years old. So I don't know if you just come out of the seat, if that's a mark from the restraint in a child seat, although I think they have different, they're placed a little differently. They go over both shoulders, I believe. But so that's the first issue, the size of the child, he's 25 kilograms, how he was restrained. And if that was an adult seatbelt, lap and shoulder belt, then there may be issues with the poor fitting of the belt that may have contributed to injuries. But that's number one. And about the physiologic parameters, the blood pressure tends to be on the low side in children, normally about 100 or 90, and the pulse can be higher. But in this case, the pulse pressure is only 13, so that's an indication of difficult loss of volume. He got 800 cc's, which is about 30 cc's per kilogram. And I think that's a reasonable resuscitation fluid. You didn't mention how much urine output he's producing. About the O2 sat, if he's intubated and he's getting 100% O2, then you expect 100% O2 saturation. So I would still be concerned. The fact that he was awake at the scene and Glasgow Coma Scale 15, and then you know, he was intubated for the flight. I think the people at the scene did a good job of making sure that he was in good shape for a 1-hour trip. And the fact that it was a 1-hour trip and he has those vital signs, I would think that he's not actively bleeding, but maybe perhaps a little bit behind in the resuscitation, or he had been bleeding and needs may need a blood transfusion. So I would still be very concerned, and I would do, you know, chest X-ray, and you can probably evaluate the pelvis easily by exam, or because the Glasgow Coma Scale is only 3, I would do a pelvic X-ray as well, and I use the ultrasound probe even before that as sort of a high-tech stethoscope. I'm sure you did also, to see what that shows. But with those marks is very concerning for possible intra-abdominal injury, bucket handle devascularization. I would be very concerned about that.
Yeah, thanks a lot. Perfect.
Thank you, Dr. Amtrak. Dr. Hodgman, do you have any comments?
No, not too much. As Dr. Untrak said, this kid, it looks to me that he should have been in a special seat for kids before being in placing the seat belt. According to what you can see on the marks, is very high. The transverse mark, the belt, it should be over the pelvis, and it's over the abdomen. So what I would suspect in this kid is to have bowel injuries, there's acceleration injuries to the bowel and the mesentery. I think this kid is in shock and is bleeding. My next step would be to give blood. And also with that mark in the chest, the other transverse mark, the thoracic wall in kids is very flexible, and you might not have fractures, but you might have severe injuries inside. So pulmonary contusion and left lobe liver injury cannot be ruled out at this time. So those are the things in terms of physiology and expected injuries. Thank you.
Thank you, Dr. Hodgman. Dr. Tassim, do you have any comments?
Actually, I don't have much to add except for a couple of points. I'm glad this boy is wearing a seat belt. In my experience in the United States, I see a lot of children in the back seat. They're not wearing seat belts in this country. I think it is sheer negligence, in my opinion. Well, be that may, one of the things that has not been mentioned is in children, the seat belt that goes across the chest, sometimes they're very loose. And so there is a tendency for these to ride high when there's a head-on crash like this boy has experienced. Hence, the seat belt that goes across the chest may go into the neck area, and I would be aware of that. Thank you.
Thank you.
And Maya, let me add you a comment and a question for everybody. So here in the United States, I know I have kids. In the first years, it's mandatory to have like the child share, and then after some years, they need to wear a booster. The booster is just the small thing that they sit on top. Just to do what Dr. Cassin just said, to avoid the seat belt to be on their neck, because something happening. And I saw a patient had tracheal injury and died because of the seat belt was not a perfect location. We would have neck injuries. I know the United States, there are laws for disease. I don't know Dr. Calderon can say about this country, but I remember in Brazil was mandatory to have this child share, but maybe a couple years ago, I don't know if this is not mandatory anymore. They changed the law, so I just want to hear. So if it's mandatory in your countries, and Dr. Menegozzo, I remember his bited question this some years ago. This is still mandatory in Brazil, or they just changed the law? Thank you, Maya. Just add in the comment for this.
Sure. Thank you. Very good question. So in Brazil, it's still a law to have these the chairs and also the booster, and it depends on whether the child is too small, or it's in medium size, or it's close to the adult body shape. So this child in particular, she was not on top of the booster. She was wearing he was wearing a 3-point seat belt, but not on the booster, which was in terms of his age and weight, it's considered the adequate position for this child specifically.
Dr. Calderon, would you like to make a comment?
Good morning. Yes, at least in Peru, everybody under law, everybody is obligated to wear a seatbelt, adults and children. And about children, I'm not really sure if it's in the law, but at least we all use those booster or special seats for children, for especially smaller children. Okay, thank you.
Thank you, Dr. Calderon. Dr. Nedelkovic, can you hear me? I guess not. Okay, Dr. Menegozzo. I mean, in India, I can comment, but like nobody wears a seatbelt. There's no rule for the seat either. So yeah, back to you, Dr. Menegozzo.
And traffic in India is very, very different from the rest of the world as well.
It's terrible. I think Dr. Antrak knows because he's visited recently.
There are a lot of tuk-tuks inside everything.
Lots of bikes. Yeah, it's
They're sitting freely on the handlebars, just sort of enjoying the traffic.
Yeah,
They got more.
family on bikes.
They're more brave than I am to do that.
Okay, perfect. So continuing on the presentation here. So these are the lab tests that came in while we were discussing the case. So he had a pH of 7.28, and I remember that the base deficit here it was 6.3, not minus 6.3. In Brazil we use base excess, so that's why it's minus 6.3, and his lactate was 37. So we can see that he's physiologically abnormal as well when we consider the lab tests. And I left this question here just as some way that we can discuss about how we would investigate these injuries. And I know that most of you would probably have everything here. It's not only ultrasound or only X-ray, but also maybe the three parts. So I'm just going to proceed with the images so you can discuss what this patient had. So first, this was the X-ray that was available in the trauma bay. So we could see that the patient was intubated. Yeah, he didn't have any signs of pneumothorax or hemothorax in the X-ray. No obvious contusions as well. And as I think Dr. Hochman commented before, the ribs of of children are so flexible that sometimes you don't have obvious fractures of the ribs, but you can still have some severe injuries inside the chest. So this X-ray was quite normal and didn't concern the trauma team too much. Patient was he underwent a fast exam as well, and on the fast exam he had bilateral lung sliding, so no signs of pneumothorax. Also, he had no fluid in lung bases bilaterally and no pericardial fluid, but the patient actually had a small amount of fluid in the pelvis. So no fluid in the Morrison's pouch or in the spinorenal space, but he did have a small amount of fluid in the pelvis. So because of the trauma mechanism and the findings, the team opted to take this patient to the tomography. So this is the CT scan of this patient. He was stable at the time. So this is the thoracic CT scan. And I'm just going to show the videos a little bit and then ask for you to comment any findings, any concerns that you might have according to the images that I'm going to show. So this was the CT scan, and this is the abdominal CT scan. I'm just going to roll the video and open for discussion for the panelists to comment. What about the findings? Were anything unusual or concerning to this patient, and also the limitations of the study? There are a lot of things to discuss here. Okay. So the thoracic CT scan was completely normal, and I think that the main idea here is to go over the abdominal CT scan and discuss the findings and what else we could do in this scenario. It's open for discussion.
Thank you, Dr. Menegozzo. Dr. Hodgman, would you like to make your comments first?
Okay, I know that I should be saying something in the CT scan, but until the image reconstruct by video is the next one goes, so it's a very low resolution. The only thing I can identify there is a little bit of free fluid in the pelvis, but I'm sure I am missing something, and I really cannot see it at the speed it's going. So I think there is something in the mesentery. I think it's a hematoma there, but honestly, it moves so fast that it's difficult to say. That's all. Sorry. There is.
Yeah, no problem.
Yeah,
So,
there is something there at the root of the mesentery. I would probably play with the windows and the levels in the scanner, but there is something there on the right side of the abdomen that in the mesentery that looks funny, but
yeah, so that was exactly the impression that we had during this case. So we can see that there is some mesenteric straining over here, and also going a little bit further down over here, a little bit of mesenteric straining. And as Dr. Hochman pointed out, you can see also a little bit of fluid inside the pelvis. It's not a great deal of fluid, but it was a small amount that was observed during the EFAST as well. And one of the issues that we have here, I'm sure that you all have been through these difficulties, is that the patient is so small and so thin that is sometimes hard to get a better look at the small bowel and the other organs. Everything is so compressed and without any abdominal fat that can help us to identify any injuries and any differences here. But one of the things that we could see in the CT scan, and it's more reassuring, is that there is no pneumoperitoneum as well. So we can see a fat straining in the mesenteric fat, and also some small fluid in the pelvis, but that's it. And we could not see anything else over the course of the CT scan. So I think we talked a little bit about the resuscitation of this patient, and I just wanted to make sure to get a grip in this situation again. So this patient was resuscitated with around 20 to 30 mLs per kilo, cc's per kilo. And the patient remained in the same situation that he was. Just a little bit, the pressure was stable, and he was still a little tachycardic, so it was around 120 heart rate. And I just wanted to discuss if you guys would do anything else in terms of resuscitation. Would you give any more fluid? Would you start him in transfusion? What would you do in this situation? And I'm going to put this poll as well in the Zoom meeting, so everyone can participate and can answer this poll to enhance the discussion. And I leave the microphone to the panelists to comment as well.
I guess when as people are voting, we can have panelists commenting. So Dr. Kasim, would you like to make your comments?
I think you have given him enough crystalloid, and if the blood pressure does not respond, which obviously it won't because of trauma, and I think I would stop the crystalloid transfusion or infusion, and then move on to, if you have whole blood, which is wonderful. Not all hospitals in the United States have whole blood, but we do have whole blood transfusion available here in Portland, Oregon, and we are lucky to have that service. And we would start the patient on whole blood transfusion and titrate gradually to see if we can get just a little higher blood pressure than what he's running at this moment. At the same time, hoping his tachycardia will respond to that as well. The one alternative there, it says none. No, that's not the right answer. Thank you.
Thank you, Dr. Kasim. Dr. Calderon, do you have any comments?
Yes, I would start with the crystalloids. Maybe he already received enough in the air transportation or the pre-hospital stage, and reassess for the if there is response in the patient. If there is not enough response, maybe some pyruvate cells. I don't see any reason for massive transfusion yet, but that's it.
Thank you, Dr. Calderon. Dr. Antrag, do you have any comments?
Yes, I agree with Dr. Calderon. It's been probably about 2 hours now since the accident, and there was no finding of a big hemoperitoneum or any other place where he lost a lot of blood, although the patient, as Dr. Hockman said, is in shock. He's got a high, high lactate, and so he needs to be resuscitated. Also, the bladder on the CT scan was distended. So I would put a Foley catheter in, and then drain the bladder and give him crystalloid until he produces about 1 to 2 cc's of urine, and at that rate, 1 to 2 cc's of urine an hour. I wouldn't wait for an hour, but be sure he's actively producing urine. And then decide whether to explore the abdomen or do a peritoneal lavage, or decide what you want to do. If there's any injury, it's in the abdomen, and he's got a seatbelt sign, so that I think the seatbelt sign by itself and then the shock physiology would be enough to go ahead and do at least a little exploratory laparotomy.
Thank you, Dr. Antrack. Dr. Hodgman, do you have any comments?
I think this kid already, you say that he received 800 cc's of crystalloids before, so he received more than the 20 mLs per kilo. Here we will activate the master transfusion protocol. Unfortunately, we don't have whole blood. If I would have whole blood, I would give this kid whole blood. And I think he needs to go to the OR. Thank you.
Could I add one other important information? Dr. Holcomb, who has been in Iraq and who has given a lot of lectures and written a lot about it, he thinks that giving crystalloid is a sin in trauma patients. I don't think I would go that far, but a small amount of crystalloid is probably acceptable. And he has very nice pictures what crystalloid does to the abdominal cavity. It swells everything up. And I have literally avoided giving crystalloid to trauma patients as much as I can, unless I'm desperate.
Thank you, Dr. Kazim. Back to you, Dr. Menegozzo.
Oh, thanks a lot. I'm sorry I didn't share the results before, but I didn't know how to work this through the Zoom, but I think I got it now. So yeah, thank you very much for the comments. We were, as you mentioned, we were a little concerned because there was no massive hematoma, no massive hemoperitoneum that could be related to this differences in lactate, in base deficit, and so on. And the patient had already received a lot of ringer lactate. So that was an issue, and we did as you mentioned. And also, what I wanted to tell, as I said before, the patient was stable. He was not in a normal state hemodynamically, but he was remaining stable along all the trauma case and the management. This were his vitals at the time, and his perfusion and pulses were also okay. And I wanted to ask you about, there was some comments also about this already, but I wanted to put this in a poll as well, so we can discuss a little bit about the management of this patient. So I'm just going to put another poll here for you guys, and make sure to answer as you want here. And so we were concerned as well about what was exactly going on in this case. Just a little bit of fluid. There was a little bit of mesenteric stranding there in the CT scan, and the team started to discuss whether or not we should operate this patient. And so these are the five alternatives that I put here for you guys to vote. So would you treat this patient non-operatively, and if so, what would you do? Would you monitor the patient with serial physical exam, with ultrasound? Would you repeat a CT scan? And if you were going to opt for a surgical procedure, would you go for a diagnostic laparoscopy, an exploratory laparotomy? What would you do? And I'm eager to hear the comments of the panelists.
Thank you, Dr. Menegozzo. Dr. Hodgman, would you like to comment?
Yeah, you can try laparoscopy. The problem is my feeling is probably going to be too much blood and it will be too difficult to explore. I don't do kits. I only do extreme emergencies if they come in. So I would probably proceed with a laparotomy.
Thank you, Dr. Hodgman. Dr. Calderon, would you like to comment?
Yes. Well, my first disclaimer is that we no longer do pediatric trauma because we have a pediatric ER with their own staff. But in this case, I want to make a comment. We have free fluid in the CT scan, and we don't have, as far as I could see, we don't have any sign of solid organ injury. So in these cases, we must be very suspicious of a bowel injury, especially if you see there is some haziness in the mesentery, the CT scan. So we would do the diagnostic laparoscopy at least. If you have the skills, the equipment we would post the patient for diagnostic laparoscopy, and we will see what exactly that fluid is. Is it blood or intestinal fluid? And we'll see. Thank you.
Thank you, Dr. Calderon. Dr. Kasim, do you have any comments?
Laparoscopy is not a good choice, in my opinion, in a patient who is in shock, because as soon as you do that, blood pressure is going to come zooming down. And I like to see with my eyes rather than the scope. And assessing this particular patient and knowing what I know about the natural history of seatbelt injury, and unfortunately he's been intubated, so he really cannot tell me whether he has any peritoneal signs or not. One of the things that I would have done very earlier on would be a plain X-ray of the spine as well. That will give me a telltale sign if there is any injury to the lumbar vertebrae, which will add to my decision to go to the operating room and for a laparotomy. I like laparotomy. I'm good at it, and I know what I'm looking for. And I will go straight to laparotomy and get the patient's problem solved. Thank you.
Thank you, Dr. Kasim. Dr. Anchak, do you have any comments?
Yes, I agree with all of those comments. I wouldn't, there's no solid organ injury and there's free fluid, presumably blood. So, you can, if you put a small scope in and you see any blood, then that's an indication for a laparotomy because, where did it come from? In this case, you have a severe mechanism of injury, a frontal motor vehicle collision, 75 miles an hour, child not properly restrained, although it's better had he not been even improperly restrained, he would have been more seriously injured. But in this, and then plus the signs of shock with no solid organ hemorrhage, I think that's an indication for a laparotomy. Now you can, you can put a scope in, see blood, and then, but immediately I would just go ahead and open, or I think you have every reason to just proceed to a laparotomy. If you find nothing, no one can criticize you. And if you don't wind up doing a laparotomy here and it doesn't go perfectly, you could be criticized. So I would proceed to laparotomy here.
Thank you, Dr. Anchak. Dr. Menegozzo, back to you.
Yeah, thanks. Thanks a lot. Very, very good comments, and just reflecting the same concerns that we had in this situation. So what we did in this particular case, we opted to do a diagnostic laparoscopy, and this is how we did it. We put the scope in this 10 millimeter port in the umbilicus, and we put two 5 millimeters ports in the mid-clavicular line to make sure we could do a diagnostic laparoscopy, full diagnostic laparoscopy. And this is how we put the patient in the operating room. We always like to operate to do diagnostic laparoscopies with the patient with the abduction of the legs, and we put also all the controllers here in the surgeon's feet to make sure we're going to control everything as well. We always use a lot of tilting of the table during diagnostic laparoscopy, so that's why we put the controllers in the surgeon's feet. And this the monitor and the video rack was was sitting at the upper left shoulder of the patient, upper left side, to make sure we could have a good visualization. So this is the, I don't know what happened. I think there are some green lines here in front of the slides, but I'm sure you can see the video that I'm going to show you. So this is the initial part of the diagnostic laparoscopy. There is some blood on the upper side of the cavity. Also, looking at the left side, you can see that there's just a little amount. There's not a lot of blood in the cavity, and we were just inspecting and making sure there were no injuries that were missed by the CT scan. In these upper parts, there was no active bleeding, so it made our procedure more easy in such terms, because there was no active bleeding. And here's we were looking at all organs in the cavity. So the stomach, you can see we're going through to the duodenum and the gallbladder there. And here's how we were inspecting the small bowel, and we were running the bowel to find the exact point where it was the stranding in the mesenteric fat, looking for small bowel injuries, as some of you mentioned it. So we are very concerned about small bowel injuries, about mesenteric injuries, and sometimes about bladder injuries. In this case, not so much because of the high urine output. So you can see that there's a single injury here that we found during the bowel running, and it's more of like a blowout injury in the anti-mesenteric aspect of the bowel. So we thought that this might be the case, probably during the compression of the abdomen against the vertebral column. This might happen. It's a blowout injury. And as Dr. Kassim said, and he made a remarkable comment about that, is sometimes you have injuries to the vertebral column. In this particular case, we didn't have any in the CT scan. So I'm going to put the last poll for you guys to answer and to participate here. And now what I wanted to ask you, what are you going to do with this injury? Would we proceed for only for suture, and it could be laparoscopic, or doing an exploratory laparotomy to make sure you handle all the rest of the cavity, and or would you perform a localized incision just to suture this part of the bowel, or you may opt to do an anastomosis with a primary resection with the primary anastomosis. I just wanted to add that during the procedure, we wanted to make sure that there were no other injuries, so we ran the bowel laparoscopically to make sure that this was the only injury, and we found only this one in this particular time of the surgery. So I'm going to open for comments here and make sure I can get the comments from you guys.
Thank you, Dr. Menegozzo. Dr. Kassim, would you like to make your comments first? Dr. Kassim? Seems like he's right here. Dr. Arnchak, would you want to make your comments first?
Yes, I think probably. Well, I won't say what you did first, but I look at that defect. It looks like it's on a lateral surface, but if you say it's truly anti-mesenteric, that would be easy enough to staple across transversely. So you don't even have to do an anastomosis or even laparoscopic suture. If you can, if you're good at suturing, fine. You know, you can go ahead and suture it, or you can put a small stapler in, and you'd have to change out one of the ports for a bigger port, a 12mm port. But you can just do a transverse stapling and be finished and irrigate. And I assume the mesentery was all okay. So, but I think that you probably did something like that. The other option would be make a small incision, just do an extracorporeal repair. and then drop it back in and close the incision. So they're all, there's no right way, but I think these days the young surgeons are pushing, this is the new frontier. So I'm trying to guess what I would do if I were a young surgeon with all these tools.
Thank you, Dr. Armstrong. Dr. Hodgman, do you want to make your comments?
I wish Dr. Untrack is probably younger than me because he can remember when he was young. I can't. Normally in a bigger kid, I would try to do it laparoscopically or maybe just exteriorize the loop and do an extracorporeal suture and push it back in. This kid is too small. I wouldn't feel comfortable. The only emergencies that I do pediatric is cases that arrive in extremis, and that was usually before and the pediatric surgeon was there. So I would probably, if I am forced to do something here, I would probably do it open. In my experience, doing laparoscopic exploration of bowel injuries like this is very easy to miss a small one in the mesenteric border. So I definitely will do this open, and it depends on what I find. I will resect or suture based on the picture there. Probably I will just repair hands-on suture of the area. Thank you.
Thank you, Dr. Hodgman. Dr. Calderon, would you like to make a comment?
Yes, I completely agree with Dr. Hodgman. He said something very true. Well, we don't do pediatrics, but sometimes we operate on very tiny people, and it's very uncomfortable doing laparoscopy in such a small room. Very difficult. You must have the skills and a lot of patience. And what would you do? There are many correct options. So I'm not participating in this poll. You can do a primary repair laparoscopically, do the resection or an anastomosis laparoscopically, or you can do an extension of the umbilical incision, like a mini laparotomy, and externalize the injured loop and whatever you can do there. They do it a primary repair or the resection and anastomosis. Either, I think. Thank you.
Thank you, Dr. Calderon. Back to you, Dr. Menegozzo.
Thanks a lot for the comments. Yeah, most of the questions there's no right or wrong. It's just to make sure that we can discuss the options in every setting. And in this particular case, I really thought about doing what Dr. Antract told us about using the stapler, but I was not comfortable with the size of the small bowel, so I opted to do a laparoscopic repair, and this I was operating this with PGY-4 in the trauma service, and we opted to do a 2-layer primary repair of this patient, and it was a little bit of we had a little bit of difficulty as Dr. Calderon said. So the space is really small, but we were able to do the suture, and we were very satisfied with exploring the whole abdomen laparoscopically. So that's why we didn't do any other incisions, or we didn't do any exploratory laparotomies, because we felt that the patient, the whole cavity was safely evaluated. And this is something that I always tell everyone. I love doing laparoscopy, especially in the trauma setting, but I'm really wanted to stress that you have to give the patient the best available treatment. So if you're not satisfied with the exploration laparoscopically, you should not have any discomfort in converting the surgery and doing an exploratory laparotomy. The whole idea is to give the patient the best surgical care and the safest surgical care as well. So that's something that I wanted to remind everyone that's watching. but we really felt that this was safe. We didn't find any other injuries. The patient has really thin mesentery, so we felt that we were not missing any mesenteric injury, any injuries in the mesenteric aspect of the small bowel. And this is how we ran the rest of the bowel, going all the way to the cecum. And I'm just going to pass this a little bit more quickly in the interest of time. And here you can see the fat straining that we saw in the CT scan. There's a hematoma here in the mesenteric bowel, in the small bowel, but there were no issues with ischemic bowel or anything like that. So that's why we were really satisfied with the exploration. You can see also some lymph nodes in the mesenteric aspect here in the small bowel. And we went all the way to the cecum. There was a serosal tear in the cecum here in the inferior aspect. We also managed to clean all the parts of the abdominal cavity, and there was also serosal tear and a little bit of hematoma in the flexure, in the hepatic flexure of the colon. So no injuries, no wall injuries in this part, at least not a through and through injury. And we went all the way to the sigmoid colon, and then all the way to the pelvis, and we aspirated the blood in the pelvis, and there was no, we found no other injuries in the abdominal cavity. So the patient went to the ICU for monitoring. He was extubated in the first day, had an oral diet in the second day, and he was discharged in the 5th day of the trauma, and he had any other issues after discharging. And during the outpatient clinic, he was really well, and nothing wrong went with the patient during his hospital stay. So I just wanted to point some of the learning points for this case that I thought were really interesting for me, at least. So just to remember something about the pediatric trauma evaluation, there are a lot of issues that we need to be aware of. And I brought this interesting review from the North American Clinic North American from 2017. And what they put in this review is that the hollow viscous injury is not so frequent in adults, but in children that they can be more frequent. And this is because the children have less muscle, they have less fat in the abdominal cavity, and also smaller areas for energy dissipation. So that's why we can have a lot more hollow viscous injury in the pediatric population. Also, they tend to discuss a little bit about the indications for CT scan. Since we are talking about pediatric population, there is a concern about overusing CT scans, but in this particular case, and they say that if you have the seatbelt sign and you have abdominal pain, or you have any other findings such as free fluid in the ultrasound, you should get a CT scan as soon as possible for these patients. Also, they discuss a little bit about the indications for laparoscopy in the pediatric trauma population. It doesn't differ a lot from the adult population, but as some of you mentioned, there are some limitations when concerning the pediatric cases because of the smaller sizes, and you have a smaller area to work with the laparoscopy. And I brought some other papers here concerning about especially the safety and the use of seat belts also, and about the physiological reserve of these patients. So sometimes when we are dealing with pediatric trauma, we need to remember that hypotension comes really, really late, and you have a lot of blood loss when this happens. So you have to get more focus on heart rate, on skin, on pulses, on lab tests. And this is very important when we are dealing with pediatric trauma. Also, it's important to remember that it's not an easy thing to get venous access from these patients, and you have to have a balanced weight-based volume infusion to make sure you're going to resuscitate these patients adequately and not putting a lot more fluid. This is a very interesting publication from Journal of the American College of Surgeons. That was they discussed the need for abdominal CT in some patients, and they found that there are five indications, 5 things that you should look for when you're dealing with these kind of people, kind of patients, and they put this in perspective for us. For you have an AST of over 200, if your abdominal exam is abnormal, if you have a chest X-ray that is abnormal, if you have report of the abdominal pain, or even abnormal pancreatic enzymes, these are all part of the evaluation of these patients and may indicate the need for CT. And they said they put it in this paper that if you have none of these five parameters, if all of them are negative, you have a negative predictive value of 99.4% for having a serious abdominal injury. So that's something that we can use in terms of dealing with pediatric patients and making sure we're not overusing CT scan. The second learning point that I wanted to bring up is about the seatbelt sign. What does it mean? So this is a very interesting article as well in Pediatric Emergency Care in 2017 about the seatbelt syndrome and seatbelt signs. So it's prevalent in 16% of the cases, and it comes with a 7% of intra-abdominal injuries. And it's also especially interesting to remember the seatbelt syndrome. So it's bruising the abdominal wall, intra-abdominal injuries, and spinal injuries. This is called the seatbelt syndrome. And the seatbelt overall reduces the burden of trauma in this population, but increases local patterns as you mentioned. So we have more intra-abdominal injuries, we can have spinal injuries, and we can have neck injuries as well because of the patterns of the seat belts. And also one of the important situations that you mentioned as well is the improper placement or the absence of booster for children. This is related to having more injuries related to the seat belt. And when you have the seat belt sign in children, you have almost 10 times the risk of having an intra-abdominal injury. So your surgery is probably therapeutic, and as Dr. Antract said, you can do a exploratory laparotomy in these situations. Even if it's negative, you won't be criticized because of the higher risk of having intra-abdominal injuries. And also the seat belt should concern us about having a small bowel injury, and you must be aware of the incidence of missing an injury in isolation. And the last learning point is about using CT scan for hollow visco injuries. This is a nice paper as well that was published in 2022 in JAMA Surgery. And they included 750 patients. Those who were only 70 had a hollow visco injury, so 10% of hollow viscous injury. And the interesting finding of this study, and what I wanted to make sure to highlight here, is that the presence of free fluid has had the most strong association with the intra-abdominal injuries. So even if you don't have any injuries to the small bowel visible in the CT scan, or if you don't have pneumoperitoneum, you don't have any fat stranding, when you have free fluid, especially in the absence of parenchymal injuries, you need to have a very special suspicion for small bowel injuries. And they said that if you look at these 8 signs, that you had none of these signs in the CT scan, you have a very probable situation of not having any injuries. They have had only one patient with serious injuries in the abdominal cavity, even with a negative CT scan. So these are extremely important findings when we're considering this kind of situations. So just to remember the differences in physiological and anatomical approaches in pediatric populations, the seatbelt sign injury in children is worse than it is in the adult population, and you have to have a high index of suspicion for hollow viscous injuries in the CT scan. So that's what I wanted to bring. I really want to hear about comments from the panelists regarding the case in the complete case, and also about the learning points. If you have any experience different from what I show, if you have any comments, I would love to hear them.
Thank you, Dr. Menegozzo. Dr. Abstract, would you like to make your comments first?
Yeah, so great case, well managed, and you got the child in and out quickly, and I assume the other people in the car were okay. Is that right? The parents and everyone, they were all okay? Yeah, okay. And a lot of times we make comments about not doing laparoscopy. We comment about what we always did. Like last week, there was a case where they put a pigtail catheter, and it probably worked as well as the big catheter, and then in an elderly patient in the chest tube, and we just comment about what I wouldn't have done that because I've always done it this way, and that's evolution. That means that we've just been practicing for many years, and the new people come along, the young people come along and do things differently, and it seems to work well. And I think that's the future. In 20 years, it's always going to be done this way. I imagine, and to make a big incision in someone's abdomen is going to be very 20th century, very second millennium, and beautifully done. I think that's a good demonstration of how to do these things. And about the other, now people are in seat belts and the chairs, whatever. I can remember when I was a small toddler, 1-year-old, sliding off the back seat when the car would stop suddenly. And at age 3, we're sitting in the front seat. We didn't wear seat belts ever, and we rode our bicycles without helmets. And now it's decades later, and I can remember it all. So it worked out well in that case. Not that they should go back to that, but there you go.
Thank you, Dr. Anjak. Dr. Hodgman, do you have any final comments?
No, I just laughing about Dr. Undra's comment because that's more or less what I always say. And my kids laugh at me and they say, "What do you mean you were riding without seatbelt?" And we survived, yeah. But no, I think it was brilliantly managed. I wouldn't have been so brave to do this laparoscopically. But you did it and it went well, and I congratulate you. You're much braver than I am. But otherwise, I really think that this was all done by the book. Perfect. Thank you.
Perfect. Thank you, Dr. Hodgman. Dr. Kasim, are you with us?
Yeah. So I want to cast a pearl, which was taught to me by Dr. Trunky. When there is one hole, look for the second hole. It's called rule of 2. And the second thing is, this patient actually did have some mesenteric serosal tear here and there, 2 areas. And those are very hard to determine with the laparoscope to see what is underneath that serosal tear. And the third thing is, Dr. Mendoza, he is a very good surgeon. He knows what he's doing with the laparoscope. I'm not used to using laparoscope because I'm old-time surgeon. I feel comfortable doing open procedure where I can see everything what I want to see and get it done, and then go home and get a good night's sleep. But the young ones that are coming up in the field of surgery, they are exceptionally good with the laparoscopy, and God bless them. And it is one of the newer addition to our armamentarium, and they will swear that they can do almost anything with the laparoscope that I used to do open. So it's a matter of what do you feel comfortable in doing, and you should do what you're good at and what you feel comfortable doing for the benefit of the patient. Thank you.
Thank you, Dr. Kasim. Thank you, Dr. Menegozzo, for presenting this wonderful case.
Thanks a lot. Hey, and thanks for the comments. I always learn a lot from you guys. You are way more experienced than I am, so I love to present this and to hear your thoughts.
I'm gonna
Thanks a lot, Carlos. Great case.
share the screen. Code.